Hi, everyone. I hope everyone can hear me okay. I'm just going to go through a couple of housekeeping things to allow any last minute joiners to come on. A couple of things with Teams meetings. If you are not wanting yourself to be seen, we are recording this as well. If you could turn off your camera, if you don't mind, then that's okay. And then I'll have everyone turn their mic off just during the presentation. There will be a little bit of time at the end for some questions. When it comes to questions, try to make them generic. Try not to use your name or anyone else's name. And then if it's a specific question, probably best to ask in a one-on-one environment. But if you have generic questions that would be helpful for all, I'm more than willing to answer those. So today's, before we start, can everyone see the first slide, a picture of me, explore your pelvic floor? Yes, no, yes, okay, perfect. So if you're having any issues throughout the presentation, please let me know. I am not looking at my chat function, so if you do need to, if you don't see the slides progressing, you can raise your hand. Or you can take your microphone off just to let me know, and we'll go from there. So the purpose of this presentation today is to just kind of start talking about your pelvic floor. You're probably all on this phone call because you've already heard about pelvic floor. You probably have some idea of what type of dysfunctions there are out there. Maybe they impact you, maybe they impact a loved one. So we're definitely seeing more traction in the area of physiotherapy when it comes to pelvic floor. I am a physiotherapist that's been practicing since 2013. That's when I took my first pelvic floor course, and I've taken a couple of additional courses in pelvic floor since then. And even in that time, the availability of therapists that offer this as a service has grown. The awareness of this and dysfunctions of this has grown, and that's one of the biggest things that we see is, this isn't a new problem. These dysfunctions have been around for quite a while, and it's an area that's more embarrassing to talk about, and people haven't talked about that or haven't had maybe the supportive environment to talk to physicians about these problems, or even family members or friends. So this is just kind of getting the conversation started. I offer pelvic floor physiotherapy services here at the Wellness Institute. I am only working on Fridays currently, but again, if you have additional questions, concerns, would like to go through with an assessment, you can definitely come and see me. We also have some great women's health courses that run throughout the Wellness Institute. So take a look at your Positively Healthy guide. You can connect with us in person, or you can reach out to anyone to kind of help assist with navigating the website if you have more questions. So we'll get started here. So did you know? Oh, I might, before we go on here, I think just check to make sure that your mics are muted so we don't get some feedback. Perfect. Awesome. Okay, so did you know that pelvic floor disorders are common, affecting up to 50% of women and 16% of men? 1 in 3 women and 1 in 9 men experience what we call incontinence, so not being able to control your bowel or your bladder. And pelvic organ prolapse is found in over 40% of Canadian women. And chronic pelvic pain affects approximately 16% of women. So these conditions are very common, and like I mentioned, not necessarily, sought out for treatment wise. Only a small fraction of people, 1 in 12, seek treatment due to the embarrassment or the lack of awareness. So this is all about building awareness into your own conditions so that you can seek the treatment. Just because you've been diagnosed with something doesn't mean that you necessarily have to live in the current state that you're in. There may be some exercises, some treatments, some behavioral changes that you can do to help impact your symptoms and improve your quality of life. So when we look into the pelvic floor, so the very high level here, we're looking at the muscles that support our internal organs, that contribute to your overall core stability, that help you control urination, so peeing and defecation, pooping, and then they also contribute to your overall sexual health. So when we're looking in here, this is your pelvis, and we have some muscles that help to do all of those things that I just mentioned. Your levator ani muscles is a group of muscles that helped to support those organs. You have your piriformis. This is an external hip rotator. Your obturator internus, your coccygeus. So the reason I like to show these muscles is because it's good for people to understand what the pelvic floor is referring to and what different intricate muscles are involved in the pelvic floor. Now, your pelvic floor, when we're talking about exercises, we're not just thinking about these specific muscles, and we'll talk about this a little bit in a bit, but it's important to know that these muscles exist. They help to provide that structure, that support. For example, the external anal sphincter helps to control that ability to poop. So if you're weak in that area, you might have some fecal incontinence. You have other muscles that will just kind of help to support things. So we'll switch to the next slide here. So I mentioned when we're talking about the pelvic floor, it's important to consider, other structures. So the pelvic floor is kind of the bottom piece. So if you think about a trampoline, if you were to stand on a trampoline, that pelvic floor needs to have a little bit of movement, right? Unless you're, a teeny tiny little baby, and you won't really see much movement there. But if you're a 160-pound individual and you step onto that trampoline has to have a little bit of give. So the pelvic floor needs to have a little bit of give as well. And then when we think about the other muscles that are involved, I often educate my patients that you have to think of it as a canister. So if you imagine having a can of pop, you have a bottom, you have a top, and then you have the surrounding environment. So that bottom piece of that can is going to be your pelvic floor that we just looked at. The canister that surrounds that is your abdominal muscles. It's your transverse abdominis, your external oblique, your internal oblique, your transverse abdominis. Sorry, I can't remember if I mentioned that one. And then you have your hip flexor muscles. And the top of that is your rib cage and your diaphragm. So when we're talking about pelvic floor exercises and incorporating those into important movements in everyday life, we want to make sure that that diaphragm and that pelvic floor, that they move together, because that's important. So we're not looking just at doing a Kegel exercise or a pelvic floor exercise. That's usually where we start. But we want to incorporate those other muscles to help provide the support that the entire body, the trunk, and the pelvis need. So if we look here, those are those muscles, the different layers of muscles that I had kind of mentioned. Another important one here to mention is your serratus anterior. Your diaphragm is located just in the bottom rib cage there. This is your psoas muscle, your iliacus, so your hip flexors, and then your pelvis in here. And then this is a really nice picture to kind of look at the inside. So again, you have your psoas, your hip flexor muscles, your quadratus lumborum, which is located in the back, your diaphragm. This is just mentioning that your diaphragm attaches into your ribs. So that's important again for exercises and learning how to control pressure. So we'll talk about that in a moment as well. And then you can see your pelvic floor at the very bottom here. So your rectum, your vagina, your urethra. So all of this is really important for controlling symptoms. So this is just kind of a good look at your anatomy. So I mentioned pressure and internal organ support. So we'll talk a little bit about pelvic floor dysfunctions. Your pelvic floor muscle contraction. What we want to see happen is when you exhale, your pelvic floor lifts and your diaphragm relaxes as air moves out of your lungs. Okay, so your diaphragm and your pelvic floor are working together. If you're holding your breath, so this is kind of a picture of your abdominal muscles, your core muscles, holding breath in there, then what happens is that air needs to go somewhere. And if it's pushing down, then that puts more pressure on your pelvic floor and it has to work harder. So we see this a lot in what we call stress incontinence. So coughing, exercising, jumping. Those are things that can kind of create some additional pressure and change the pressure within the abdominal wall to make it difficult for you to then hold your pee or your poop. So what we want to see is we want to see us breathing easily, contracting that pelvic floor, contracting your core to support your back, to support your abdomen, and being able to control where that pressure and where that breath goes. So this is just a pelvic floor muscle contraction. The correct action would be the pelvic floor lifts, the deep abdominal muscles draw in, and there's no change in your breathing affecting your affecting your pelvic floor. Incorrect would be pulling the belly button in towards your backbone, or pulling your belly button in towards your spine, and then holding your breath, causing a bearing down motion. And then this is showing the relationship with the diaphragm shortening and lowering to expand your lungs. So as you breathe in, your lungs fill up with air, your diaphragm has to move down, and with that, your pelvic floor muscles are also moving down. So that co-contraction. When you exhale, air leaves your lungs and the diaphragm can ascend upwards. Your pelvic floor also ascends upwards at that point. So the reason that that's important is because, yes, we all kind of, when we have issues like incontinence, we think automatically, okay, my pelvic floor is not strong enough to hold in my urine. But you can actually have a whole bunch of different issues kind of contributing to that. Excuse me. One of those is if you're holding stress or tension in your pelvic floor and it has limited ability to move, like that trampoline that should move up and down, you can be strong, but you don't have the movement there, which then again creates a pressure issue, which can contribute to symptoms of incontinence. So pelvic floor dysfunction. By the age of 80, about 11% of women will have one or more surgical interventions for urinary incontinence or pelvic organ prolapse. Pelvic floor dysfunction can affect up to 50% of childbearing women. It's important to note you don't necessarily need to childbear in order to have pelvic floor dysfunction, but in individuals that do go through pregnancy, you are more likely to experience that. And for women of childbearing age, pelvic floor dysfunction and pelvic organ prolapse are very common. So 65.8% of women over 40 years old report at least one complaint of sexual dysfunction. So that's important. Another thing that pelvic floor physiotherapy can help and assist with. And then the last kind of stat on this slide is in the United States, 10 to 20% of individuals are affected by defecation disorders, accounting for 1.2 million annual physician visits. I like to put this one in there if you have constipation. And a lot of us will have constipation, you know, every now and then. But chronic constipation, a chronic cough, those can all contribute to pelvic floor issues down the road. So the number one thing that we go through in a pelvic floor assessment is subjectively listening to kind of what your complaint is, and then also seeing what are your habits. What do you have for fiber? What is your water intake like? Have you had any diet changes? So those things can all impact your bowel movements, which then can impact your pelvic floor as well. So pelvic floor dysfunction, when we're talking about pelvic floor dysfunction, one of the more common that we see in the clinic is incontinence. We'll talk about types of incontinence in a moment. There is prolapse, urgency. Those are another couple of dysfunctions that are quite common when people come in for a pelvic floor assessment. I also put in this slide here rectus diastasis or diastasis recti. So we don't talk too much about this in this presentation here, but I just wanted to include it because it wasn't one of the ones that was in the nice little image here. But if you do have diastasis recti, that is something that we can address in the clinic and teach you how to exercise properly to protect your core, your pelvic floor, and progress you. So pelvic floor pelvic floor dysfunction, pelvic organ prolapse. So what I mean by that is you have your pelvic floor muscles, like your trampoline, holding up your bladder, holding up your uterus, holding up your rectum. So when we look at this, and the top left corner here, we have your anatomy without any prolapse happening. And it's important to note that it's normal for your organs to shift a little bit inside of you. So that's normal. But what we're looking for is, you know, is there any abnormal shifting? Are there any symptoms of this impacting your ability to pee or to poop? Or are you feeling any pressure? One of the most common symptoms that individuals with coming to the clinic have is heaviness located in their vagina area or the rectal area. But you can have pelvic organ prolapse without even knowing it. So here we're looking at your vagina, your uterus, your cervix, your bladder sitting in the front, and your rectum sitting in the back here. And just note this angle here. There is about a 80 to 90 degree angle of your rectum, and that's important for how to poop properly. So we'll talk about that in a little bit. But when we're looking at this, this is kind of what your normal should look like inside your body. And your pelvic floor is right along here, and it's holding everything up and supporting those structures. So we're talking about a cystocele. That is your bladder. So your bladder has fallen into the anterior vaginal wall, so that maybe there's a little bit of protrusion in here. There's different grades to a cystocele. So when we do an internal exam, we look to see how much movement there is from the bladder, and where does it sit when you're at rest? Where does it sit when you bear down, when you cough? And sometimes we'll even do a standing assessment to see where you're at from that perspective as well. So that's a cystocele, is your bladder. Your rectocele is your rectum. So that falls into the posterior vaginal wall, causes some pressure closer to the backside. And again, multiple different grades of that as well. We have uterine prolapse. So that's when your uterus falls closer to your vaginal opening. And we have an enterocele. So that this is for the individuals that may have had a hysterectomy. So you have no more uterus, you have no more cervix, but there's still space here. So sometimes those intestines can fall down into that space. And again, different grades for that as well. And then you have a vaginal vault prolapse here. So these are just the different types of prolapse that you can have. Another common pelvic floor dysfunction is urinary incontinence. So when we're looking at the anatomy, so we have your key muscles that we kind of want to look at, and what types of things do they do? What are their roles? So you have your internal urethra sphincter, and that is smooth muscle, involuntary. It's located at the bladder neck, and it primarily stops urine leakage from occurring. And then you have your external urethra sphincter. So that is skeletal muscle. It has some voluntary control, and it surrounds the urethra down, lower down, to provide that assistance. And it's crucial for intentional urine release. So, contracting, relaxing can kind of help with emptying the bladder. And then you have your pelvic floor muscles that act as a sling, supporting the bladder, the bowel, and the reproductive organs, and they assist in urination. So when we're looking at this, we have the male bladder, we have the female bladder, and then we have those urethral sphincters that we were talking about. This is a cross section, and then we have their urethra. So the urine builds up within this bladder here, and then eventually comes down into the urethra, and that's how we get rid of our urine. So when we're looking at types of incontinence, we're looking at stress incontinence. So that's this first picture here. So you see these little black arrows, that's pressure coming from above and pushing downwards onto the bladder due to increased abdominal pressure or increased stress or weak pelvic floor muscles not being able to hold everything in. Then we have our urge incontinence. So we have these little red arrows here against the bladder as well, the bladder wall. And when we're thinking about urge, we may not have a full bladder, but we may feel the need to pee. We feel like our bladder is full. We can't hold it. We need to go to the bathroom. So it's that involuntary contraction of the bladder muscles telling us, oh, you got to pee, but you don't really need to pee. So that one, again, very common, takes some time. What usually happens is we've developed a little bit of a bad habit in going to the bathroom when we don't need to. And I have done this with my own children, but we have a tendency to seek out a washroom before we need to actually go to the bathroom. We do this before we leave the house. We do this maybe before, leaving work. So your bladder isn't full. You're not allowing it to fill to capacity. And over time, your bladder capacity becomes smaller, not because your bladder has shrunk, but because your tolerance to hold urine is lower. And then the next one here we have is overflow incontinence. So this is usually due to some type of blockage. Here, the blockage is at the prostate. But if you have a kidney stone, if you have a tumor, if you have some neurological conditions can cause overflow incontinence as well. Then that causes some leakage when your bladder is too full and you're not aware that your bladder is full. And then we have that neurogenic incontinence, again, due to a disturbed function of the nervous system. So that the brain is not connecting with the nerves. So it's not allowing you to know, when you need to pee and when you don't. So when we talk about pelvic floor dysfunction, urgency and frequency, so this is having to go to the bathroom right away, can't hold it, or having to visit the bathroom multiple times a day. And lots, like every half an hour, every hour, more than normal. When we're looking at what we kind of use for education is this curve. So it's normal to have urgency. It's our body's way of telling us, oh, okay, bladder's full, have to go to the bathroom. So there's normal urge curves, and then there's abnormal urge curves. So when we look at this urge here, we should see a little bit of a bell curve distribution. Depending on where your threshold is, sometimes your urge curves can look, a little bit higher, but this is kind of your generic normal urge curve. Now, these red lines are here. When you experience urgency or frequency, one thing that we look at is, okay, with urge, we don't want you going to the bathroom when you're experiencing that need to pee right away, because that's going to be the hardest time for your bladder to be controlled by your pelvic floor when your urgency is at its highest here. So what I instruct people to do is to try to distract yourself. And sometimes it's helpful to do a pelvic floor contraction or a Kegel, where you hold your pelvic floor for 3 to 5 seconds, if you can, until that urge suppresses and you start to kind of come down the mountain here. Because once you get past this red line and your urge isn't at its highest point, then it's easier to get to the bathroom. So number one thing is if you have to pee real bad, don't go right away. Try to get through that urgency curve so that you don't have an accident on the way to the bathroom. This is just kind of showing the abnormal things that can happen when you have that urgency happening where the bladder is contracting, but you don't really have to pee. And then this is a really good diagram for kind of showing you as someone who visits the washroom very frequently. We usually get people to do a bladder diary so that you know where your start point is. So how often are you actually going to the bathroom? How much are you actually peeing? So I'll have people measure their pee into a container to see what is normal for them. So what we're trying to work on with that frequency is, okay, if you have an urge to pee, maybe you can get through that first urge. Let's try to delay until maybe that second urge that you're going to the bathroom, rather than going right away at every single urge. Then when you notice, okay, it's becoming a little bit easier, I can wait for 2 urges and I'm still going to the bathroom every, let's say, hour. Okay, let's try to make it to the third. And then still utilizing that concept of, okay, when this green line is here, that's the part where I can make it to the washroom safely. This is the part where I can make it to the washroom safely. Now, there will be a time where you will have to go to the bathroom. Your bladder can only hold so much. So when you get to that point and you have these urges back to back, like someone would need to pee in this case. But we're looking to kind of prolong the time that you're going to the washroom when you're visiting the bathroom, 12, 13, 14 times a day, slowly making that improvement. And this takes time because it's usually a habit that's developed over a period of months or years. So how often should I pee? So normal is about 6 to 8 times a day. Everyone's a little bit different. So if you're, a 9 time a day peer, it's not the end of the world. But if you notice that it's impacting your quality of life, or, okay, this is not my normal, I used to be able to hold it for, 3-4 hours and I'm only able to hold it for an hour and a half or 2 hours, then making some of those behavioral changes can impact things. The other thing that I'll note with urgency is diet tends to play a big role in urgency sometimes. So things like caffeine, things like being dehydrated. So what we tend to do when we are going to the bathroom frequently is try to restrict the amount of fluid in our bladder because we don't want to go to the bathroom. But what happens is you become dehydrated, your bladder becomes irritated because it is dehydrated and very concentrated urine, and then that causes it to contract, needing you to go to the bathroom. So we do want to stay hydrated, and that's a little bit different for everyone, but general guideline, 6 to 8 glasses of water a day. Unless your doctor has told you otherwise. But number one thing is don't dehydrate yourself. It can make your symptoms worse. And then the bottom picture here is, again, just kind of explaining that urge wave. Urgency comes, it grows, it peaks, then it subsides and it stops. So you're going to sit, you're going to be still, you're going to squeeze your pelvic floor muscles quickly. You can do it 5 times or you can do a hold. You're going to wait either half a minute, whatever you need to wait until that urge goes away. And then if the urgency persists, you're going to use distraction techniques. And once the urgency lessens or stops, we're going to wait and then we're going to walk slowly to the bathroom. So pelvic floor dysfunction and management. So we talked a little bit about some of these in the previous slides. But a couple of quick tips for you to take from this. So limiting and avoiding bladder irritants. So your caffeine, your alcohol, your acidic food or drink, your artificial sweeteners, your carbonated beverages, spicy foods. Everyone's a little bit different, but that's why keeping a bladder diary is nice, because then you'll quickly see, okay, this is an irritant for me. By increasing your fiber intake. A little caveat with this one, your fiber intake, if you're increasing it, you also need to increase your water intake. Otherwise, it can make constipation issues and like stomach bloating, pain issues. You're going to increase your water intake if you've been dehydrating yourself or you're not kind of at the recommended limit. Smoking can also be a trigger for frequently visiting the bathroom. So if you can quit smoking, multiple benefits in quitting smoking. You're going to treat your chronic cough. So if you have allergies, if you have postnasal drip, you want to talk to your doctor about those things. As you're coughing and coughing and coughing over years, that puts a lot of pressure on your pelvic floor. So treating that, it's a good idea. You're going to practice some good bathroom habits. We'll talk a little bit about that. There are medications that can assist in some of these conditions. So again, talk to your doctor. Pessaries. This is, again, something we don't get into too much during this chat today. But in the event that you have prolapse and then your organs have fallen to a point where it's impacting your quality of life, and you're feeling a lot of pressure, a pessary is a device that you can insert into your vagina that helps to support some of those structures. So a doctor needs to fit you for that here in Manitoba. So that's something that we would refer for if we thought that that was a good option. And we always try to utilize conservative care first. So your pelvic floor physiotherapy, your exercises, your habits. And then if that's not working for prolapse, we sometimes would recommend referral for a pessary. And if you're at a certain point where they think maybe the pessary won't help, or they're recommending surgery. So sometimes they will make that recommendation in some cases. Not everyone needs surgery though. And then the bottom is just pelvic floor physiotherapy. So there's lots of things that we can do to help treat the symptoms associated with some of these conditions. So pelvic floor muscle training, myofascial release, trigger point massage, joint mobilization, biofeedback. Those are some of the tools that we use within the pelvic floor physiotherapy to help with your symptoms. So pelvic floor muscle training. So this usually involves coordinating your pelvic floor with your breathing. It usually involves some amount of strength. We're looking to see what's your ability to contract those muscles initially. Can we get that stronger? We look at your power. So how quickly can you contract? How long can you hold that for? What's your endurance like? What's your motor control like? Are you able to turn those muscles on, or are you someone that struggles with knowing where those muscles are? Those muscles are small, they're intrinsic, and you don't get the visual of the same that you would when you're contracting your biceps and your elbow is moving up and down. So sometimes people have a really hard time with understanding, am I doing this right? Am I doing this correctly? What's happening? So that's where biofeedback can come in handy sometimes. And some people are great. They know exactly what they're doing, and they just need to have some exercises to kind of practice and continue. And then your breathing. So breathing is important. We usually try to coordinate your pelvic floor contracting with an exhale at first, and then relaxing on your inhale, just to help with that ability for the pelvic floor to move up and down with your diaphragm. And once that coordination is there, then we look to progress that into some activities that are more relatable to what your goals are for physio. So just down here, this is a quote from an article here. More than 1/3 of women report not feeling confident about their ability to do pelvic floor muscle contractions correctly. So again, another thing that pelvic floor assessment can help with. Where am I at? Giving you an idea of what your strength is, what your endurance is like, so that you can continue to practice those things. And maybe you're just kind of coming in for a check to see, okay, where am I at? Good, I'm happy with that. 3 years down the road, if something starts to happen, then you kind of have a baseline for that as well. So what are proper potty habits? So I have a couple of kids and recently went through potty training. So just like children, we need to have proper potty habits as well as adults. So the number one thing is we're going to relax, we're going to not strain, and we're going to not push. This is it can happen for P2, but particularly when you're having a bowel movement. So the tendency for, I would say most people, is that when you're having that bowel movement, you want to do that Valsalva, you want to push down. And there is some extent of, needing to get that out, but as you push, sometimes that can make your pelvic floor tighten, working against what you're trying to do. So we want you to try and relax that pelvic floor as you're having that bowel movement. If you'll remember, I made note of, the rectum has a natural kink to it. So another important thing is to be able to rotate your pelvis back a little bit. And something that we'll use for that is to have a stool in front of you. So some of you may have heard of the squatty potties. Those are nice stools that kind of fit in nicely and tuck into the toilet. So it's not a tripping hazard as much. But if you don't have one of those, you can use just a regular stool. You put your feet up on the stool, and that allows your hips to flex a little bit more and your pelvis to posteriorly rotate, and that affects the angle that the rectum sits at. So the poop can kind of fall out a little bit easier there. So that's one thing that you can try. And then don't sit and scroll. So this has become a big thing with phones. You want to make sure that you're not sitting longer than you have to on the toilet, because again, that just creates pressure issues. If you don't need to be sitting there and trying to poop, if you're not needing to poop, then don't do it. This comment here about the breath, the ow. So one thing that you can do rather than pushing, just try to belly breathe. So inhale it through your nose. Exhale. So again, that helps with the pressure. So that's something that you can kind of try to do at home as well. So how much water and fiber should I aim for? So this is kind of just a general guideline, 1.5 to 2 liters, so 6 to 8 cups of water a day. Increasing 250 milliliters per 30 minutes of activity. So again, if you're someone that exercises a lot, you may need a little bit more water because you're losing that water through sweat. Fiber is also an important component. We talked about constipation. So women need about 25 grams of fiber per day, and men need about 38 grams of fiber per day. So a lot of us are not hitting our fiber goals. Dietary sources are preferable, and supplements should be discussed with your healthcare provider. And again, this is something drug interactions, you want to make sure that that's okay. The big one is if you're taking something like a Metamucil or fiber supplement and you're not increasing your water intake, that can cause some tummy pain, some bloating, some negative side effects. So couple of high fiber foods listed here. Your all bran has about 27 grams per cup. Your fiber one, same thing. Lots of beans, lentils, prunes, dried fruits, coconut milk, nuts, fruits and veggies. So this is not an exhaustive list, but some ideas on, okay, these are things that I can kind of add into my diet that might help. So I'm cognizant of time here. We're almost done. So I just wanted to talk a little bit about, how do I do a pelvic floor contraction? What is a Kegel? So it's hard to kind of do this over Teams here, but there's a couple of images, and I just want to point out here the one on the right hand side. I always tell people when you're first learning how to do it and coordinate those muscles, try to imagine yourself in a nice, relaxing environment. Try not to do it with your kids right beside you because that's not very relaxing. In most cases anyways, and try to make it kind of, a one-on-one time. You don't need to spend a lot of time doing it. If you set a timer for 5 minutes and however many you get in that 5 minutes, great. On the inhale, you're going to try to relax your pelvic floor and let everything go. On your exhale, what you're going to envision is your pelvic floor squeezing and slowly kind of lifting upwards, just like the elevator there. So you're slowly lifting the pelvic floor up. You don't want to feel any downward pressure, and you want to feel more of an upward pressure, like your pelvic floor is lifting towards your belly button. This sometimes takes practice. So you want to breathe, you want to squeeze, lift, and then you want to relax as well. So inhale, pelvic floor relaxes, ribs grow wide. Exhale, squeezing the pelvic floor and lifting it up. So getting that movement with your diaphragm, learning how to contract those muscles and relax those muscles. Some things to keep in mind with exercise, because of the anatomy, because the pelvic floor is important, because the core and the diaphragm are important, and our muscles attached to our rib cage, into our pelvis, into our femur. We want to pay attention to our rib cage. We want to pay attention to our hip and back mobility. Restrictions in some of those can cause some imbalances in our muscles, and it can also prevent us from breathing properly. A lot of the time we'll breathe really well into our tummy, but our posture is not great, and we have that limited back extension, or we're really tight in our rib cage. So when we're breathing in, the pressure or the air has nowhere to go but down. So we want to kind of redistribute that pressure into a 360-degree vision. When we're breathing, we're allowing the pelvic floor to lengthen and expand. So, expanding, relaxing. And then strengthening that pelvic floor. So different parameters for endurance, different parameters for strengthening, depending on what you need. And then stretching, if for someone who's more on the hypertonic side or the tight side. And then pressure management. So leading with a pelvic floor lift with any of the exercises that you're doing. So let's say you're doing a deadlift. Sometimes, telling yourself, okay, I'm going to lift my pelvic floor, contract my lower abdominal muscles, and then I'm going to do my deadlift, so that you're constantly thinking of that pelvic floor and that pressure before you're even doing that exercise. The pelvic floor will co-contract with other muscles during activity. So sometimes if it's a little bit harder for you, we'll do some exercises that get your adductors working, so that you're able to kind of get a little bit of strength in there as well. And then we're always loading towards your goals. So progressing, loading the muscle, utilizing those same muscles, same muscle training principles that we use in other training. So these are just some beginner exercises that I like to use in the clinic. So here we have an exercise that kind of focuses on breathing. There is a little resistance band. You can use a belt. It's just wrapped around the lower rib cage, and all you're doing is you're breathing and you're trying to contract and relax your pelvic floor, focusing on the inhale to grow those rib cage, that rib cage nice and wide, and to expand your back body as well. This one here is nice. You can kind of barely see it. There's a little yoga block underneath my sacrum here. So this is kind of a nice position to start in for those that may be experiencing some heaviness because of prolapse. Your hips are elevated. Gravity is kind of helping to pull everything back to maybe closer to where it should be. And then practicing those exercises in that position. Here we have
Lisa.
Yeah.
We just can't see anything on our screens here.
Sorry, thank you.
That's okay.
There we go. So this was the first one, that breathing exercise. This was the second one with the yoga block underneath. These couple are progressions of a pelvic floor contraction with a heel slide, marches. So again, utilizing different muscles as you're contracting your pelvic floor to progress to those more common exercises that you may do in everyday life. We don't live life on our back. Some stretches. So this one here is a happy baby stretch. Great stretch to open up the back of the pelvic floor. This is a bridge. Again, utilizing your adductors by squeezing a yoga block or a pillow. That helps with strengthening the pelvic floor and the glutes. This is, again, a range of motion exercise, really great to kind of get the tailbone moving. So your cat-cows, your wide knee child's pose, your puppy pose, again, a really great stretch for your lower back and coccyx. Your deep squat position here to open up the back of the pelvic floor, and then your hip flexor stretch to kind of open up the front of the pelvic floor there too. So these are not the only exercises. These are just some beginner exercises to kind of start thinking of. It is great to get assessed by a pelvic floor physiotherapist. If you're comfortable in doing that, they'll do an internal examination. After asking you some questions and getting your consent, they should let you know kind of where you're at from a strength endurance perspective, from a tissue quality perspective. If they see any dryness, anything like that, they'll let you know. But to get assessed, to kind of see what you're working with, and to have some of those recommendations kind of right off the bat is a great place to start. So I hope some of this information was helpful to you. Obviously, it's very basic for people to kind of just start thinking about these things. But now we'll leave a little bit of time for questions here, if you have any. No questions? And if you feel uncomfortable and you don't want to ask questions, that's totally fine too. You can always connect with me in the clinic. Their phone number is 204-632-3910. And you can book an appointment with myself or another physiotherapist for other conditions too. Yeah, so thanks for joining us today. I hope that some of this was helpful. The other thing that would be helpful for me is if you have specific topics or things that you'd like maybe a little bit more information on. It's always good to hear from you guys, just to know what you would like to hear, so that when we're planning these in the future, if there's an opportunity to kind of do something on a topic that's been brought up by you guys, we try to incorporate that in as well. So thanks, everyone. Have a good day.